Welcome to our next session, which is on who is the most vulnerable in a pandemic. And I'd like to welcome our online viewers and our viewers in person. We have 4 guests with us today that will join. And I wanted to open the session really by first talking about how great this symposium has been. Having experienced yesterday's talks, it was really good to put in perspective how we experience life and the challenges of life relative to everyone around the globe. And I think the pandemic has really put this in perspective for us. So many of us have been wondering when the pandemic hit how we might get our food delivered to our house. People around the world, including in San Antonio, are thinking about whether they have food. We have individuals who are thinking about, should I get my 4th booster vaccine? And there are people around the world who are just hoping that they get the vaccine. So we all experience the world in a very different way. And there are a lot of disparities. And that really is the topic for our conversation today, which is who is most vulnerable in a pandemic. And I want to introduce our 4 guests. Amalia Adler-Waxman, who is the Vice President and Global Head of Environment, Social and Governance at Teva Pharmaceuticals. Gugu Ngubane, Vice President, Global Head, Environment, Social and Governance at Teva Pharmaceuticals. I think I have that title wrong, I'm really sorry. Rishi Manchanda, President and CEO at HealthBegins, and Tubi Retta, Deputy Director at Girls Opportunity Alliance from the Obama Foundation. I'm going to start with Amalia and ask for a short discussion about approaches from Teva and their perspective on issues globally, access to medicine in the context of the pandemic and addressing blind spots that we have, as well as really providing access to medicine programs for statusless people. Amalia?
Hello. Hi. Hi. Can you hear me okay?
Yes, we can.
Great. So hello, everybody, and thank you for inviting me. And it's a pleasure to share a little bit of what we do in the context of access and health equity. So what I'll try to cover first, I'll just introduce who Teva is very briefly, because I'm not sure everybody knows. I will speak about our access to medicine in the context of our environmental, social, and governance strategy and what we do in some countries, especially in Africa and also in Israel. And then I will touch on a health equity study that we just conducted for vulnerable populations in North America, in the US, with Morehouse, which really talks about the pandemic impact on vulnerable populations. So the first thing, just briefly, Teva Pharmaceuticals is a global pharmaceutical company. We're one of the largest generic companies in the world. We also have a specialty portfolio. We operate in 60 countries. We have 53 manufacturing and R&D sites in the world, and we have about 37,000 employees, and we have probably the most substantial footprint on medicines that are listed on the WHO list of essential medicines. We are headquartered in Israel. Our largest market is in North America, but we are, as I said, operate in about 60 countries. And lastly, we've been established 120 years ago here in Israel, in Jerusalem. So at Teva Pharmaceuticals, we have a strategy which is related to environment, social, and governance. And I won't spend time on the whole of the strategy, but it's important to note that it's integral to our business strategy. And because access to medicine is really who we are and what we do as a company, because generics is part of, how you really make medicines more affordable to more people in more places. The most material topic from an ESG perspective for us is access to medicine. And in this context, 2 years ago, we made several commitments to access to medicines, all the way from linking the executive compensation at Teva to access to achievements around access to medicine, to being a partner in pandemics and emergencies to governments, but also increasing volume submissions, registration of products, as well as embedding more considerations also in the R&D process for medicines to increase access, especially to those who cannot reach them through existing systems. And specifically, we also committed to launching 8 access programs that are dedicated for vulnerable populations across the globe. And these programs will range from low middle income countries, but also in countries where we operate, such as in North America, where there are a lot of needs as well. And there are many people who are off the grid from an insurance and health coverage perspective. So now I'll just say a few words on some of the programs that we've already launched in Africa and in Israel, and then I'll elaborate on the health equity work that we started to do in the US in the context of the pandemic. So about 2 years ago, we launched, we joined a very exciting program that is actually led by Texas Kids and Baylor in a few countries in sub-Saharan Africa. And this is to address the problem of lack of access to medicines as well as treatment and diagnosis for children with cancer in Africa. And just a small data that is staggering, in developed countries, about 80% of children with cancer survive cancer. In Africa, about 90% of children with cancer die. So this gap divide is something that is really hard to accept. And we've been approached by Texas Kids 2 years ago, and it was them who really told us that of 30 medicines that are required in the protocol for these kids, we have a very large number in our portfolio. So we teamed up and we committed for a long-term donation of these products. And it's a donation due to lack of current financing for these products in those countries. The first pilot was launched in Malawi, but the program is already running in Botswana and Uganda, and it's about to be launched in a few other countries such as Rwanda and Kenya, Tanzania, other countries in Africa. We also teamed up with Breast Cancer International, and we all work on this program with an organization called Direct Relief. It's an organization that specializes in product donations to low and middle income countries as well as emergencies, including in the current crisis in Ukraine, by the way. And we work also with Breast Cancer International. It's a program, it's an NGO, a program in Ghana to provide medicines for breast cancer for 2 hospitals in the capital, in Accra, where we provide about 8 products from our portfolio just for this program. In Israel, we have universal health coverage, but despite the fact that there is universal health coverage, there is a small group, not large group, of statusless people. These are people who are asylum seekers, refugees, who are currently within the state of Israel, and they are not covered by the health insurance of the general population. Majority of them are in the southern part of Tel Aviv, and we teamed up with 3 clinics and a pharmacy to provide also medicines for acute and chronic conditions for these patients. So these are 3 already from the 8 programs that we've committed to launch. Now, very recently, we teamed with Morehouse and we did a Harris poll on healthcare access barriers in North America. And basically, to provide some context, we did a survey, and our goals in the survey were really to understand the impact from COVID-19 and being able to assess access gaps in access to care. And we actually intend to turn these insights into actions, and we are in the process of establishing also an access to medicine program in the US that is really in the context of the findings of this program. And I want to share some numbers related to this program. So not surprisingly, we saw during the pandemic people who delay or cancel healthcare services. And notably, 64 of these people are Black, Indigenous, and people of color who delayed their healthcare, needs more often. And while fear of exposure to COVID-19 was the primary reason, it's important to note that other reasons for delaying care were existing access barriers. So COVID-19 actually exacerbated some of this. And other reasons include inability to take time off, lack of childcare, and lack of transportation. And this was especially true for younger people, for women, for less educated, from lower income households. The survey found that approximately 40% of healthcare providers report that the overall health of the patients they see has worsened since before the pandemic. Both persisted and emerging barriers to access health and to accessing health exist. And we specifically saw issues related also to mental health. More than 80% of doctors reported an uptick in mental health diagnosis, and nearly 2 in 3, 65%, also mentioned worsening conditions among pre-diagnosed patients. And again, our research shows that the pandemic worsened the health equity gap. And but there are solutions, and that are beginning to make some difference. And looking ahead, we found that telehealth is expected to be a prominent approach addressing healthcare. And we all know that during COVID-19, telehealth has become one of the critical solutions for in healthcare equity and gaps. But at the same time, we know that telehealth is still not accessible by everyone, with more than 1 in 3 physicians and about half of pharmacists noting that most of the patients they serve are from low-income households and do not have the means to easily access telehealth. When we think about this type of solutions, it shows that it's also so important to think about the consumer's experience. Do they have access to Wi-Fi? Can they easily access a computer? Accessing healthcare is not just about healthcare services, but it's about what individuals face day to day in their life. And with this in mind, I just want to conclude here that what we try to do at Teva is look at access really from a broad perspective. And from what I've said, you can see that there are very different challenges in very different parts of the world, whether it's a complete lack of access to care, to treatment, to diagnosis, such as in Africa that existed before and of course exacerbated during the pandemic, off-the-grid patients in many countries where there is very strong health system, and then COVID-19 and health equity issues that have been exacerbated during COVID-19. So I'll hand it over back to you.
Thank you. Thank you so much. Thank you so much for that. Let me make some corrections. Gugu Ngubane is the executive head of Health Response Solidarity Fund in South Africa, and I apologize for that oversight. And we have a fifth guest, Amalia Adler-Waxman, who is the Chief Commercial Officer of Novartis, and welcome. I'm going to turn now to Tubi, and I'd really like to hear what the Girls' Opportunity Alliance has been doing to address a lot of these disparities.
Yeah, thank you so much. Really excited to be here and to be part of this important conversation. As you mentioned, I help lead the Girls' Opportunity Alliance, which is a program of the Obama Foundation, and we focus on advancing adolescent girls' education and empowerment around the world. I'll just start off by saying something that I think we all know to be true, which is that the pandemic has really laid bare and exacerbated longstanding inequities that have disproportionately impacted historically marginalized communities around the world, and particularly women and girls of color. Even before the pandemic, we were facing a global education crisis around the world. We knew that there were more than 130 million girls who were out of school, and primarily in the global South. And over the last 20 years, we had actually started to see a lot of progress with increasing numbers of girls going to school. However, the period of school closures that we have seen because of the pandemic is threatening that progress that we've made, and is likely to result in millions of more girls who will never return to school because of the school closures. And we know that this will have a ripple effect on the lives of girls, and not just girls, but also their families, their communities, countries, and just our world at large. And the disruptions in education have not only led to learning losses at a magnitude that we have never seen before, but have also put girls' health and well-being at risk for a number of reasons. So during the pandemic, girls became at increased risk for child marriage because of the school closures and because of increased poverty resulting from the pandemic. And so right now, globally, 13 million more child marriages are projected to take place by 2030. Again, reversing some of the gains that we had started to see. We also saw a sharp increase in the number of unintended pregnancies among young girls. So as schools begin to reopen, these girls are particularly vulnerable because they actually won't return to school, especially in countries where there are stigmas of teen mothers being in school. And in some countries, there are actually prohibitions against young girls who are mothers or are pregnant returning to school. And then relatedly, we all know that, health systems around the world were disrupted because of the pandemic. And so that meant that women and girls had reduced access to critical services. And so when girls became pregnant, they didn't have access to the health services that they needed. Women and girls also had a hard time accessing menstrual products and contraceptives. They also lost access to really important family planning services. And so in 2020, we saw that lead to 1.4 million unintended pregnancies in 115 low and middle income countries around the world. We also saw and continue to see a surge of gender-based violence against women and girls. In some countries, we saw up to a 33% increase in violence facing women and girls. And again, this puts their lives at risk when they don't have access to the health services that they need in response to that violence. And then, we also saw that women and girls have been particularly just vulnerable and at risk because they shoulder the responsibilities of household care work. And so when women, especially those who work in the informal sector in low and middle income countries, were the first to lose their jobs, we saw trickle down effects to their families and young girls. And girls who were home from school were also the first to take on household chores. And again, this was a challenge that girls were facing even before the pandemic. Before the pandemic, girls between the ages of 10 and 14 on average did 50% more in unpaid work compared to boys. And so this means that they are not able to go to school, not able to fulfill their potential and access critical services that they need. And then lastly, we saw during the pandemic, and we continue to see a tremendous mental health crisis among young girls around the world, including right here in the US. Again, women and girls are, the ones that bear the brunt of crises, including the pandemic. And here in the US, we have seen an exponential increase in emergency room visits by young girls, and particularly girls of color. In early 2021, there were 50% more emergency room visits for attempted suicides among girls between the ages of 12 to 17. And again, this is something that we're seeing not only in the US, but across the world. And so these multiple and intersecting challenges that women and girls face, I think really require cross-sectoral responses and solutions at a scale that we've never seen before. At the Girls Opportunity Alliance, we are focused on supporting community-based organizations who are on the front lines supporting girls and women in these communities. And one of the things that we've learned is that these community-based organizations have developed trust with the girls and the communities that they serve. And so during the pandemic, when it was really hard to reach girls because they weren't in school or because they don't have access to digital learning, these organizations were able to step in quickly, provide food, provide menstrual products, provide alternative learning opportunities, provide ways for girls to report incidences of gender-based violence. And so we really believe deeply in making sure that the solutions that are at the forefront are being led by community-based organizations and leaders from the communities that are being the most impacted. We've been proud to support these organizations. During the height of the pandemic, we provided microgrants to help extend their reach and help make sure that they were able to provide the resources that girls need. But again, it really means that the scale of the issues that we're seeing means that we have to have a multi sort of sectoral approach and include the voices of those that are most marginalized as we develop solutions. Thank you.
Thank you so much. I think we started our morning with our commissioner talking about the importance of mental health and caring for individuals who really need some assistance. And I think that theme has continued already in our first two panelists. I want to welcome our panelists three. Gugu, you were happily, I'm asking you to talk about inequity and availability in accessing services in South Africa. And I know you have a lot of stories to tell about how you've been managing the pandemic.
Thank you very much. I'm really happy and honored to be in this panel. I want to start by saying that in a pandemic of this nature, what we did realize is that we are all vulnerable in different measure. However, there is always those who are most vulnerable and worse affected than others. At the beginning of the pandemic in the country, there was a memo that did the rounds that said, we are not all in the boat, but we definitely are all in the same storm. And basically what that was raising is that whilst we are experiencing this pandemic, we are all experiencing it differently, and there will be issues of inequitable access to information, to services, and what then do we do about that? In the country, we have a wealth of resources, researchers, information systems, statistics SA has an innovative online mapping tool that actually maps out the vulnerable populations and provides a vulnerability index. And whilst we know that COVID disproportionately affects the elderly and those with underlying health conditions, however, there's more communities that are vulnerable. And we know that in our country, there are people who are poor, who live in deprived conditions. There's overcrowding. There are people who live in informal settlements. There are people who live in multi-generational households with about 4 generations in one household in a very small dwelling. And that's provided serious challenges to the COVID protocols and restrictions that were provided. So I decided that I'm just going to bring in a few voices of the vulnerable population. My workplace let go of everyone over the age of 60 because they didn't want to take responsibility if one of us gets the virus. So I had to go into early pension. However, this is not enough to keep my family. My brothers sign a little bit, but it isn't much. My mother, who is late, knew sign language better. Now, I don't know what is happening with this COVID. You must take off your mask when signing with other deaf people. They need to see your lips and your mouth. It's part of the language. I was scared because I have health problems. If I got infected by COVID, then I would die with the lockdowns. I'm scared to go to the clinic to catch COVID, but at the same time, I'm scared I'm gonna die if I don't go to get my monthly supplies. I live with an elderly parent. I can't send him because I can't go out because he is an elder and is more at risk. The pandemic has been a battle between either dying of starvation or of COVID. As a community in the informal settlements, we do not intentionally want to disobey the COVID protocols of social distancing, lockdown, sanitizing, masking. It's just that the conditions are not practical for us. We live in a shack with 6 people. We can't isolate a person who's sick. We can't quarantine. Social distancing is impossible. We use public transport with 16 other people inside a taxi. We have no running water or even soap at times to wash our hands and sanitize. When one person is sick, we are all at risk. The government said even us as foreign nationals will be vaccinated, but I don't have documents, and the system requires that I have a number before I get registered and I'm able to be vaccinated. I'm scared for my family and for myself. Then I want to take a comment from MSF, who was based in the rural KZN, KwaZulu-Natal, one of the provinces that has a lot of rural dwellings and traditional communities. In a place like rural KwaZulu-Natal, the pandemic has exposed horrendous inequities in the health system. Distances between clinics are greater. Access to the clinics can be expensive, may include crossing a river. Essential services are far, and some of them are not well resourced. Innovation, technology does not necessarily always include context of our settings. So in terms of who then is vulnerable in South Africa, with over 60 million people in our country, 16% are insured and have the privilege of accessing private healthcare, which has been very quick and ensured that most of the insured get vaccinated. And they were definitely the first ones that accessed the vaccinations, more than the 84% that relies on government public health services. So I divided the vulnerable of our society into three. There are those that we know, people living with disability, more than 3.8 million in the country, where communication at times was not very sensitive to their needs, and they did not get all the information that they required. And so is access to services. Some of it is not really disability friendly. We know about the elderly, but more especially the elderly that live in rural areas, that come from poor families, who have issues of food security, who have issues of access to healthcare. People with mental health, mental illness, they could not access services. They continue to be discriminated against, and their plight became even more. Women and children are the most vulnerable in any pandemic. People living in rural areas in South Africa constitute about 32.65%. They need a different model to those living in urban areas for them to be able to access services. And as a result, mobile vaccine services were provided. Community health workers were sent to help with screening for COVID, for people to be able to be tested. But the reality is that not everyone who had COVID symptoms could actually access testing. One, because testing was very expensive. It was expensive even for those who could afford it. Secondly, because when going to the public services, sometimes you'll find that the clinic is closed because one person was found to be positive. Or when you do get a test, you get the results maybe 2 weeks after, or when a person has already died. People living under poverty and with no food security become more vulnerable, and they were more especially vulnerable during the hard lockdowns. Between April and May 2020 alone, one of the research done in the country showed that the proportion of households with adults and children who experience hunger rose up from 8% in 2018 to up to 24% in just that period alone, between April and May 2020. We cannot forget the informal employment sector, people who are unemployed, people who are self-employed, people who are informal traders, small businesses who lost sources of income during the lockdown. And I want to also raise the issue of the migrants, the refugees, where it was discovered that our interventions were not really migrant aware in terms of how exactly we're going to ensure that the services access these people. And then there were vulnerable people that were directly impacted by the pandemic. And I think in the keynotes address this morning, the issue of the healthcare workers, essential services workers that really died in the call of duty, who their lives were also threatened, but we still needed to get services. And pregnant women who also had to suffer in terms of getting services. We know that this pandemic came at a time where this, specifically for South Africa, we have many colliding pandemics and calamities. The HIV burden, we have over 8 million people living with HIV. The distribution of chronic medication and ARVs was disrupted. TB testing declined by 26%. We know it's one of in fact, it has come back to be the top cause of death in our country. The maternal and child mortality increased. One of the studies showed that maternal deaths increased by 40% in just 2020 alone, still births by 10%, and neonatal deaths by 3%. And we saw a high number of teenage pregnancies, about 34,587 teenagers who fell pregnant just in 2020 alone. And I want to bring a group that the children. Children were neglected in the early response of the pandemic, because we did not think that they were under the same threat, and we were overwhelmed by the adults' cases. But we know that with Omicron, we started seeing children being affected by COVID. And in South Africa, we've started vaccinating children, but from the age of 12 to 17, the school-going age. And more than 2 million have been vaccinated already. But children were also affected in terms of being exposed to domestic violence, the part of gender-based violence, and there's a lot of femicide in the country. 1 in 5 women experience physical abuse, and the cases just worsened during the lockdown. Another issue about the children is that some of them are child-headed households, and the only meal they get is through the school feeding scheme. And when the schools are closed, then they don't get a meal. So how did we respond to this? I think our government realized the vulnerability that they were under during the pandemic. And a solidarity fund, where I'm coming from, was established, which is an independent structure. It's a public benefits organization. We received donations within 4 months of the establishment of that structure. We had 3 billion rands of donations that came from citizens, from organizations, from the private sector, from business, from other countries as well, which was completely phenomenal. And what we realized is that when we mapped out, because our role was really additional to what the government response was, and we did not want to replicate, we collaborated with private sector, with business, with the researchers. There was a very, very impressive leadership in the country, very impressive innovation, which are the themes of this conference. And the projects that we selected, we realized that the health system is probably the one that is carrying the worst burden. So it's the most vulnerable in terms of just the system. And we supported the PPEs. We supported local manufacturing of ventilators, because we knew that with the increasing need for ICU beds and oxygen and ventilation, ventilators will definitely be needed. We've also supported with just procuring more equipment, because with COVID being an infectious disease, you need isolated areas to do investigations of patients who are suspected to have COVID. We also supported research to understand the local pandemic. On top of that, we are currently supporting the vaccines. And with the vaccines, it's one of our proudest supports, because we have assisted in the additional 1 million more jabs to be done in the country, where we are literally going to rural areas through mobile healthcare services and partnering with NGOs in the country. And other support that we've provided is food relief, having fed more than 300,000 families through food parcels. We also supported gender-based violence in terms of providing more shelters. We also supported small businesses who experienced loss of income. And I think what also happened during COVID, because we know that life doesn't stop, we also had an unrest last year in July, where the already vulnerable communities through COVID experienced more loss of income, loss of jobs, and more poverty. And we supported those communities, and we supported those businesses. And then now we are experiencing the floods in KwaZulu-Natal, which I'm sure that have been globally broadcasted. That I can confidently say is still the very same population, the very same communities that were hard hit by COVID and were hard hit by the July unrest. So climate change is a serious pandemic that is becoming an issue in our country already. So just in closing, I would say what do we need to invest in is to take the lessons from the COVID response and make sure that we strengthen the systems that are in place, because we realize that there's a wealth of systems that are working for communities that are in the rural areas. There is no one size fit all. Every local customized solutions are needed so that you are able to reach the people that are more vulnerable. And if you contact community leaders, traditional leaders, they know the families that are most affected. And it was very humbling to realize that they would tell you that no, that family, we are fine, but those families, and they'll show you the location, are the ones that need food more than any other location. And I think that's a powerful story to tell, and I hope it gets captured in some of the qualitative research that is being done to show the impact of COVID. So I think I will close with just saying that the Solidarity Fund realized that really COVID response, much as COVID may amplify the inequities, however, we have so much wealth if we work together. And in the African proverb, you can go fast if you go alone, but together we can really go far. And with the COVID response, it was a mixture of both, because we had a very clear mandate. We are all working towards the same goal. So we really have gone far together, but at the same time, individuals needed to go fast because the response had to be rapid, it had to be agile, so that we are able to reach as many people as possible. Thank you very much.
Thank you so much. A wealth of information, really very interesting. I now turn to Rishi to talk about health inequity in communities across the US.
Well, first, thank you so much. It's truly an honor to be among this esteemed company here, and my special thanks, of course, to our hosts for today. I know that my time is brief, and so I will actually maybe take this opportunity in being asked to describe inequities, health inequities in particular, as they manifest in the US, to reflect and share some reflections on the experience of many of the partners, the allies, the organizations that my organization has the privilege of working with. My name is Rishi Manchanda. I'm CEO at HealthBegins. I'm a primary and public health trained physician. My organization, HealthBegins, is a mission-driven organization based in the US with a mission to advance health equity, particularly radical transformation in health equity. And the way we deliver on that mission is by working with our healthcare partners, community partners, and public health organizations to address the social and the structural drivers of health equity. I need not go into the details because they've been laid out beautifully through the prior presenters about the ways in which the last 2 years in particular have just laid bare the ways in which inequities have been the tracks along which violence, the violence of the pandemic, the violence of, in some cases, state violence, has been implemented. This is not for all of us who care about equity, who've been in this work for a long time. This is not new, tragically. Right? This is not new information, although it's essential for us to bear witness and chronicle and research the ways these inequities manifest and show harm. What I want to reflect on is the way in which this conversation is taking part in some parts of the U.S. and see if I can link that perhaps to some of the incredible wisdom and insights and remarkable work that's been described here today. In the U.S., as many of you are probably familiar with, there's been for some years now a surge in interest in the social determinants of health, particularly from those in healthcare who have awakened to this term and starting to embrace it to be able to try to understand all of those forces that impact the health of our patients that exist outside the walls of our hospitals and clinics. At the same time, especially in the past 2 years, in the wake of the murder of George Floyd, Breonna Taylor, others, in the context, of course, of a pandemic that was visibly, deeply inequitable in terms of who was living and who was getting infected and who was dying. In the wake of all those things, what has been remarkable is to actually understand that while there's been a lot of work to respond to the harms and inequities that have been manifest in marginalized communities across the US, in healthcare, there's still a challenge that we have, a challenge in understanding these inequities and these harms from a structural lens. And that challenge, my thesis here today, if anything, is that challenge that leads to decreased awareness among healthcare professionals and those who have resources and privilege to be able to do something about the things that at the structural level are causing these problems, and that actually perpetuates inequity. But let me kind of make my case by not talking about data for a second, but actually just going back to something that we can all relate to. You've all heard an ancient proverb, if you give a man a fish, you feed him for a day. If you teach a man a fish, you feed him for a lifetime. It's such a deeply ingrained kind of story, especially as we think about the mental models that we applied in healthcare in the US in particular to how we view the needs of the patients we serve, the communities we serve. But that proverb is actually wholly inadequate. Why not teach a woman to fish? What if the pond next to the home of that person is polluted? What if their family and their neighbors have been historically denied access to the very resources and opportunities to fish in the first place? The rods, the tackles, the permits to fish, etc., due to poverty, xenophobia, racism, homophobia. My point here is that what we've uncovered, I think, in the past couple of years is that while there is remarkable work that's happening in healthcare, one of the challenges that has emerged is what happens when we lack a structural analysis. And at the same time, what we've seen are incredible examples of how those in healthcare, those in public health, and those in communities, especially in community-based organizations who come together in place-based collaboratives around the country, can actually take a structural lens and be able to demonstrate remarkable effectiveness in being able to identify inequities and then be able to address them. So I'll give you a couple of examples. Again, just more context, the work that we do at HealthBegins is to provide consulting, training, and solidarity really with a variety of organizations like the American Medical Association. We've been supporting the CMS Accountable Health Communities model, which is a federal model to be able to screen for and address social needs of patients. We work with the largest health systems in the country to, again, address these social needs. But one of the things that we've seen, for example, is that in these healthcare settings, as we look at inequities, far too many of our peers, far too many of us, as highly trained, incredibly successful professionals with deep quality and safety training, deep technical expertise when it comes to health services research, for example, and so on, deep training in the clinical skills of providing great care. One of the things that we've found is that there's been a challenge in looking at inequities as just disparities, as if most of our job is simply to quantify and bear witness to the injuries that our patients, especially some patients, due to structural forces are experiencing without really kind of inserting ourselves into that narrative. In other words, to be a dispassionate observer of the inequities, document them, but not necessarily think about what is required of us. So, for example, we see that in the quality improvement space, many healthcare professionals truly understand this adage that every system is perfectly designed to get the results it gets. for those in quality improvement, for those in performance improvement and healthcare systems across the world. We understand that adage. But we often don't apply that to the question of equity. So for example, if we're seeing vast inequities as the pandemic has laid bare and exacerbated in healthcare outcomes, maternal health outcomes, for example, or outcomes in terms of COVID vaccine access, outcomes in diabetes, outcomes in mental health, if we're seeing these inequities and our healthcare system is part of the supposed solution, but if the inequities are showing up among our patients, isn't it true then that the system itself is designed to actually perpetuate, if not ignore, these inequities? The recognition that I'm trying to kind of speak to here without taking too much time here is that the inequities that we're describing here, I think particularly in the context of the US, where we've been at this work for some time, is best understood when we realize that we're talking about harm. And in that context, we can draw on the words of the late Paul Farmer, for example, and start to apply a structural analysis to this work. Paul Farmer and many others around the world use the term structural violence to describe this relationship. The definition that he shared and others shared several years ago was this. The term structural violence is one way of describing social arrangements that put individuals and populations in harm's way. These arrangements are structural because they are embedded in the political and economic organization of our social world, and they are violent because they cause injury to people, typically not the people who are responsible for perpetuating those inequities. When we work with many healthcare leaders across the country, and what we're seeing happening now among the most courageous of those healthcare leaders and their partners in the community is this understanding, is this application of a structural lens to understand that the inequities that we're all documenting here and describing in exacting detail are actually manifestations of harm caused by structures. And that requires increasing competency, what some scholars call a structural competency, to understand the forms by which structural violence exacts harm on specific groups of people. So for example, there are forms of structural violence that many of those in movements, social sciences, research, and increasingly in healthcare have been talking about. For example, the structural violence of wealth extraction and generational poverty in the US, the structural violence of housing and school segregation, the structural violence of healthcare segregation and profiteering that continues to exist in the US. For example, in the US, medical debt is the #1 driver of new poverty and has been so for a long time. The majority, according to a 2021 study, the majority of the top 100 hospitals in the US were taking part in providing charging prices that were more than five times the actual cost of care to the hospital. The implications of those are profound because those same hospitals are also part of a systemic practice of then pursuing the reclaiming of that wealth from their patients through aggressive debt collection practices, with a variety of hospitals across the country engaged sometimes in egregious lawsuits against their very patients. So healthcare profiteering and segregation, because of the racialized nature of this, is one of those forms of structural violence. Hyperincarceration is another form of structural violence that we see manifesting in our clinics and hospitals every day. 70 million Americans have a criminal record. Disenfranchisement is another one. And then finally, sexism and anti-LGBTQ violence. 14 states, including Texas, as you know, have put forward laws that are anti-trans, that are specifically targeting individuals who are arguably, by all the evidence, all the data, the most vulnerable. One of the things that we're not doing enough in healthcare, I think, is bringing a structural analysis to understanding and discussing with rigor and clarity these forms of structural violence, and then thinking about what health equity truly requires, which is not just more innovative programs and not just necessary response efforts to address the needs of those being harmed, but structural action to prevent those harms in the first place. First, start with to understand how structural forces like poverty and racism, homophobia, nativism are exacting harm on people. So for example, that means using data-driven questions to bring together those in clinical care, those in patient experience, those in quality safety, those in human resources, those in financial and operations divisions within large health systems, to ask how well are we doing in identifying harm caused by structural forms of violence? How can we use the data that we have to be able to identify if we're doing a good job at just identifying the harm? The second step, and these are my last two comments here, is that beyond understanding how these structural forces are causing harm for the patients and the communities we serve, how do we acknowledge the ways in which our own healthcare systems have ignored or even continued to perpetuate these harms? A healthcare system in North Carolina called Cone Health was part of a lawsuit in 1963 that was trying to desegregate U.S. healthcare. Cone Health was in 1963 the white hospital in Greensboro, North Carolina, and there was a black hospital. 9 plaintiffs, black dentists and physicians, sued Cone Health. They won the case, and desegregation ensued. From 1963, it took to 2016, or 50 years later, for the health system to acknowledge and apologize to the last living plaintiff in that case.
Rishi,
Healthcare systems,
really
and all of us have to be able to.
sorry. I'm really
I'm
sorry.
so sorry, and I'll end by saying this.
I'm so incredibly. I'm sorry to do this.
Yeah, I'll just say thank you. And sorry for going over time. Go ahead.
No, incredibly compelling, and thank you for your thoughts. And I'm sorry I had to cut you short. I know, Emmanuel, you are, I think, on the call. Maybe not. So I think we have to wrap up. I don't know if we have time for questions. I think we're going to have to close. I want to thank everyone on this call and this session very much for their thoughts. Really compelling discussion, and I appreciate you all participating. Thank you so much.